Hello, everyone, and welcome to today's webinar, Empowering Communities Through Health Literacy Strategies for Effective Engagement and Impact. My name is Scarlett Juarez, and I'll be your moderator for this session. We're thrilled to have you join us for this important discussion in how community-driven health literacy initiatives can create lasting change. We're honored to have with us today Harneet Chima, founder and director from University of Ottawa, and Manraj Chima, program collaborator from University of Ottawa. Just a disclosure statement, none of the speakers for today's webinar have relevant financial relationships to disclose with ineligible companies. And before we get started, there's just a few quick housekeeping items. All attendees will be muted during the webinar. If you have any questions, please use the Q&A feature, and questions will be answered at the end of the presentation. Please use the chat box for comments and discussions related to the webinar topic. This session will be recorded and made available for those who may want to visit the discussion later on the Health Literacy Solutions Center. You will also receive an email containing a link to a brief evaluation. If you are requesting continuing education credits, you must submit this evaluation in order to receive your CE certificate. I do encourage everyone to ask questions, so feel free to submit them in the Q&A box throughout the session, and we'll address as many of them at the Q&A portion at the end. With that, let's go ahead and dive in, and I'll turn it over to Harneet and Manraj to introduce themselves.
All right. Hello, everyone, and welcome. My name is Harneet Chima, and I'm very excited to have you join us for this webinar today. So a little bit about me. I'm the founder and director of the Health Literacy Program, which is a community-driven initiative meant to improve health literacy by empowering individuals to take control of their health. I've done work in health education and program development to find evidence-based solutions that address health disparities in rural and underserved areas. Joining me today is Manraj Chima, who has played a very important role in helping implement various aspects of this health literacy program, which we will discuss with you all today. I'll let him introduce himself.
Thank you. Hello, everyone. I'm very excited to be a part of this webinar today. A little bit about me. I'm a current undergraduate student at the University of Ottawa, working towards a degree in health sciences. I have a very strong interest in community engagement, public health, and healthcare accessibility. I'm a collaborator in Harneet's health literacy program and help support the mission to improve health literacy and build sustainable partnerships that drive long-term impact. Thank you.
Over the next 40 or so minutes, we're going to take you on a journey, not just through what our health literacy program does, but also how we built it, the lessons we've learned, and how you can take similar approaches in your own communities. Today, our focus is on how we developed this multifaceted, community-driven, sustainable health literacy program that's working to improve health literacy in rural Ontario. And with that, we can get started. Before we dive into the why behind this program and how we built it, we can begin with the basics. What is the Health Literacy Program and what does it do? From the beginning, my goal was to create a community-driven health literacy intervention designed to improve access to clear and actionable health information, empower individuals to take control of their health, and ensure that both adults and youth are equipped with both knowledge and resources that they need to make informed health decisions. This program is structured around 3 core pillars, and each is designed to target a different aspect of health literacy and ensure that we reach people across all age groups. This is because I firmly believe that sustainable health literacy can't just be a one-time intervention. It needs to be woven into the fabric of the community itself. And the first pillar is the research-based intervention. That focuses primarily on adults in the community. The goal is simple: to improve diabetes-related health literacy in a measurable and sustainable way. But how do we actually do that? Well, we designed a structured health literacy intervention that follows a pre and post interventional model. This means that before we conduct any educational sessions, we first collect baseline data on the participants' knowledge of diabetes. This includes what they know about risk factors, prevention, symptoms, and management. This is done through anonymous surveys to ensure honest responses without fear of judgment or any bias. Then we deliver a tailored educational session that focuses on key areas. One of those being understanding the diabetes related risk factors. This helps people recognize early warning signs. Secondarily, nutrition and lifestyle changes, meaning breaking down simple changes that one can make to prevent or manage diabetes. Thirdly, navigating healthcare resources. And fourth, self-management skills. This means teaching individuals how to monitor their health effectively, including how to use a glucometer. After the session, we conduct a follow-up assessment that measures improvements in knowledge, confidence, and self-efficacy. This allows us to track whether this intervention is actually making a difference and identify areas where people still need support.
While the research-based intervention focuses on adults, it is important to note that health literacy must be taught early to create generational change. If we wait until adulthood to teach people about health, we're already too late. That's why youth engagement is a core part of this program, so that health literacy becomes a lifelong skill rather than simply a reaction to health problems later in life. This program approaches youth engagement in multiple ways, but one of the most effective strategies has been hosting health-focused events designed specifically for young people. These aren't traditional sit and listen lectures. These are interactive, hands-on events that make health literacy both engaging and relevant. For example, on February 24th, I helped Ternit host a health and wellness fair at the local community high school. This event wasn't just about giving students information, it was about giving them practical experiences. At this event, we held mindfulness and yoga sessions to emphasize the importance of mental health. We provided hands-on nutrition workshops where students learned how to make simple yet healthy meals. And we connected students with local healthcare and wellness organizations so they knew where to turn when they needed support. One of the key reasons this works so well is because long-term partnerships have been built with schools, principals, and teachers. If we had tried to do a one-off event without these strong relationships in place, it wouldn't have had the same impact. By engaging educators as partners, this program ensures that health literacy is embedded into school culture, not just for a single day, but as an ongoing priority. Beyond school events, Harneet and I are members of a youth working group, an official subcommittee of the local municipality of this target community that includes youth from the target community itself. This means that young people in the community have a voice in shaping health initiatives and are actively involved in carrying this work forward. By empowering youth leaders today, we can ensure that programs like this continue long after we're gone.
The third and final pillar of our program is providing health kits to youth, because health literacy isn't just about what you know, it's also about having access to resources that you need to take care of yourself. Many youth in rural and underserved communities unfortunately lack some basic health essentials, so we designed customized health kits to address those gaps. Now, instead of just creating one standard kit for all ages, we recognized that the health needs of, say, a kindergartner are very different from those of a high school senior. And so we worked very closely with teachers and school staff to understand what every student in each grade level needs. Each teacher responsible for a different grade gave us insights into what their students lacked the most. And this allowed us to create grade-specific health kits tailored to the unique needs of different age groups. For example, younger students received kits with basic first aid items, hygiene products, and educational materials on personal health, Middle school students received additional mental health resources and self-care materials, and high school students were given more advanced wellness materials, menstrual products, and first aid essentials. We also work discreetly with teachers to identify students with unique needs and customize their kits accordingly. For instance, if a student required, let's say, additional menstrual products or specific hygiene items, we ensured that they received what they needed without drawing attention to it. This personalized approach makes sure that we're meeting the needs of students in a way that's both thoughtful and also stigma-free. And so, to summarize, this program takes a multifaceted approach. Number one, we target adults through a research-based diabetes education intervention. Number two, we empower youth through engagement events, leadership opportunities, and school partnerships. And number three, we provide tangible resources through customized health kits that address real identified needs. This approach ensures that we're meeting people where they are, addressing immediate knowledge gaps, and equipping both current and future generations with the tools that they need to take control of their health. And with this foundation in place, we can now dive deeper into why listening to a community before designing a program is essential, and how we ensured that this program wasn't just created for the community, but created with the community at every single step. And that brings us into strategy number one, listen to the community first. So when we first started thinking about this initiative, we recognized a fundamental truth. Health literacy is one of the most significant determinants of health outcomes, and it disproportionately affects rural and underserved populations. But before we could create a meaningful intervention, we needed to answer a critical question. What does this specific community actually need? Many well-intended health initiatives falter because they start with the solution first, rather than taking the time to properly define the problem. In public health, one of the biggest mistakes organizations can make is assuming that their expertise alone is enough to determine the best course of action. However, research has repeatedly shown that top-down approaches, where interventions are designed without consulting the community, are far less effective than community-driven models. When a program is built in isolation from those that it's meant to serve, it risks being irrelevant or underutilized or rejected altogether.
One of the most well-documented frameworks for effective community-driven health interventions is community-based participatory research, or CBPR for short. This model involves actively engaging the community and identifying problems and co-creating solutions rather than simply imposing external interventions. Studies have shown that CBPR leads to better health outcomes and greater program sustainability rather than the traditional top-down approaches. By involving the community directly, CBPR ensures that interventions are not only relevant and practical, but also foster trust, ownership, and just long-term engagement, all of which are very essential for a program like this to succeed beyond its initial implementations.
Listening is a crucial but often overlooked step in public health work. Many organizations, even with the best intentions, can falter if they fail to integrate community voices from the start. Instead of assuming we understood the problem based on statistics or external research, we went directly into the community and we asked people to describe their own lived experiences. And the goal here was to let them define the problem rather than using our own preconceptions or judgments to do so. And this is where qualitative data became just as valuable as quantitative data. While we could look at epidemiological data showing high diabetes rates, those numbers alone wouldn't tell us why diabetes self-management was so difficult. We needed to ask the people directly impacted questions like, were there financial barriers to healthy eating? Was there misinformation about diabetes treatment? Or were there gaps somewhere in the healthcare system itself that made it difficult to access services? To answer these questions, we engaged directly with community stakeholders through structured conversations, one-on-one and group discussions. Our goal was to build a complete multi-perspective understanding of the health literacy barriers that people faced. I spoke to local healthcare providers who could tell us what health conditions they saw the most frequently and what barriers their patients faced in seeking care, as well as to community leaders who understood the cultural and socioeconomic factors influencing health behaviors. And I also spoke to school educators who saw firsthand on a daily basis what students lacked in terms of health resources and knowledge. And lastly, I also spoke to local government officials who could provide some more insight into the existing public health policies and funding opportunities as well. One of the most critical takeaways from these conversations was that while diabetes was a major health concern in the community, the deeper issue here was a lack of health literacy around the condition. People weren't just struggling with diabetes, they were struggling with understanding diabetes. And this distinction was very important because it shifted my approach. If we had simply responded to the high diabetes prevalence with increased screenings or clinical interventions, it wouldn't have been enough. The real barrier was not just access to healthcare, but knowledge, awareness, and self-efficacy. People lacked the tools and the confidence to navigate their own health.
So this is where health literacy becomes not just an individual issue, but rather a systemic one. The World Health Organization defines health literacy as the ability to obtain, understand, and apply health information to make informed decisions about one's health. But here's the key takeaway. Health literacy is not just the responsibility of individuals, but it's the responsibility of systems and communities to provide accessible, clear, and culturally relevant information. People can't just make informed decisions about their health if the information provided is unclear, inaccessible, or just not adapted to their needs.
And so, the first big lesson we learned, and something I hope everyone here is able to take away, is that before designing a solution, you must first understand the problem as defined by the community itself. This approach ensures that one, interventions are relevant and effective because they address real needs, not assumed or perceived needs. And two, programs are embraced rather than resisted because they reflect community input and have cultural context. And thirdly, long-term engagement is possible because people feel a sense of ownership and trust when they're included in the process from the very beginning. This foundation of deep community engagement is what shaped every aspect of our program moving forward. It wasn't just about teaching people about diabetes or general health and wellness. It was about building a system of trust, accessibility, and sustainability that could support better health outcomes for years to come. And that brings us to our second strategy, building long-term partnerships for sustainability. Now, at this point, we've identified the key issue, low diabetes-related health literacy, and we did so by engaging with the community directly. However, identifying a problem is the first step. The next challenge is ensuring that the solution we build does not fade away after a few months or even a few years, but instead becomes deeply embedded in the community in a way that allows it to sustain itself over time. And that's what brings us to this second strategy. One of the most common reasons why well-intentioned health initiatives may struggle initially is that they rely too heavily on a single organization or individual or a temporary funding cycle. When that initial driving force is removed, the program may collapse or experience troubles. A truly impactful intervention must be structured in a way that allows it to become a natural part of the existing community framework, rather than something external that depends entirely on outside involvement. And public health research supports this approach. Studies show that programs with strong multi-sector partnerships are significantly more likely to succeed than those operating in isolation. The World Health Organization emphasizes that sustainable health interventions must integrate into existing community structures, empower local leaders to take ownership, and leverage diverse partnerships to create a strong network. This is exactly what I aim to do with the health literacy program.
Now, to make this program sustainable, meaning partnerships were built with key stakeholders who already played essential roles in the community's health ecosystem. These included government officials, municipal councils, and just general those in power who provided structural and policy support. Healthcare providers who offered clinical expertise and a direct link to patient populations, as well as educators who allowed the integration of health literacy into schools, and community organizations and businesses, which as a result contributed additional resources and helped expand the program's reach. Each of these partnerships was essential for different reasons. The municipal government partnership allowed for the establishment of the Youth Working Group as an official subcommittee, ensuring that young people had a formal role in shaping local health initiatives, like myself. The program's collaboration with healthcare providers ensured that the diabetes education efforts aligned with real-world patient needs, making them much more effective. And the schools provided a crucial platform to reach young people early, embedding health literacy into education systems rather than treating it as simply an external or one-time effort. These partnerships transformed the program from something external into something the community itself owned and maintained. Instead of being reliant on any individuals or short-term funding, it instead became embedded within existing community systems, thus making it much more resilient and adaptable over time.
One example of how these partnerships have translated into lasting impact is the way that we worked with local schools to teach students about the concept of health literacy. Initially, we were delivering individual workshops and health fairs, but through ongoing collaboration with educators, we were able to develop more structured, long-term initiatives. This means that even if we were to step away, health literacy remains a priority within the school itself. And similarly, our partnerships allowed us to secure nearly 10,000 in grants, expanding our ability to provide resources such as the health kits for youth. Without these long-term funding sources and institutional support, these initiatives may have remained small scale and unable to reach the wider community as effectively. And so this approach demonstrates that sustainability is not just about ensuring that a program lasts. It's about ensuring that it continues to evolve and expand in the community, even beyond the original leaders. By embedding health literacy efforts into existing community structures, we ensure that the impact of this program will continue for years to come. For anyone looking to build a long-term, impactful community health initiative, the key takeaway here is that sustainability is not achieved by doing everything yourself. It is achieved by ensuring that the work becomes part of the existing community framework. Programs that are integrated into local institutions, whether that be schools or healthcare systems or municipal councils, have the highest likelihood of lasting impact. When you build long-term partnerships, you're not just creating a program, you're creating a movement that can continue to grow long after you step away. And that brings us to our third strategy, engaging youth for generational impact. When we talk about long-term sustainability in public health, one of the most important strategies is ensuring that the next generation is engaged and empowered to take ownership of their health. Studies show that health behaviors developed during childhood and adolescence often persist into adulthood, meaning that the earlier we instill strong health literacy skills, the greater the long-term benefits. And that is why our third major strategy is focused on youth engagement, because real lasting change does not just happen in one generation. If we want health literacy to be an integral part of the community, it has to start with young people.
So, to ensure youth engagement was meaningful, long-term, and impactful, it was approached in two key ways. Firstly, through establishing the Youth Working Group, an official municipal subcommittee that gives young people a direct role in shaping community health initiatives, as mentioned earlier, of course. The second key way was through hosting youth-centered health literacy events. This involved bringing engaging, hands-on health education directly to schools and youth spaces. One of the most impactful examples of this, as mentioned before, was the Health and Wellness Fair recently hosted at the local high school. At the Health and Wellness Fair, the event was structured to immerse students in real-world health skills rather than simply lecturing to them. The activities included yoga sessions, smoothie making sessions, mental health jeopardy, and a slew of booths from local organizations essentially meant to support youth health and wellness. One of the reasons this event had such a strong impact is because we built it through collaboration with schools, principals, and teachers. Health literacy doesn't just happen in one-off events. It needs to be integrated into school culture so that students continue to change with these concepts throughout their education.
Beyond school-based events, we took youth engagement a step further by creating a youth working group within the community. This means that young people in the community have a permanent structured role in health decision-making. This group is made up of high school and college students from the local area who help design and implement health initiatives that are relevant to themselves and their peers, as well as provide feedback on health literacy programs and workshops to ensure that they stay youth-friendly. And thirdly, engage in leadership development so that they can continue advocating for public health long after they graduate or possibly move away. Now, by empowering young people to take an active role in health literacy, again, we're ensuring that these efforts do not disappear over time. Youth involvement means that health literacy will continue to evolve with each new generation rather than being dependent on a single group of leaders. This is how we shift health literacy from a short-term intervention to a long-term movement. By equipping young people with knowledge, leadership skills, and real opportunities to change and shape their community's health, we're investing in a healthier future for generations to come. And so, a key takeaway here is that if you're looking to build a long-term sustainable health initiative, investing in youth engagement is one of the most effective strategies. By involving young people in both education and leadership, we're ensuring that the next generation not only understands health literacy, but also takes ownership of it. And that's what leads to real lasting change. Next, we're going to take a look at the research-based intervention, measuring and improving health literacy. Now that we've discussed the importance of community engagement, long-term partnerships, and youth involvement, we can talk about evaluation and measurement, which is another key aspect of ensuring impact. In public health, interventions that lack proper evaluation may often risk being ineffective or misaligned with community needs or unsustainable. If we aren't systematically tracking outcomes, we may assume that our efforts are making a difference when in reality, the intervention might not be addressing the right issue in the right way. Research from the World Health Organization and the CDC highlight that the most effective health literacy programs use evidence-based evaluation frameworks. These frameworks allow us to track knowledge improvement, behavior change, and overall program effectiveness. This is why our intervention was structured as a pre- and post-interventional model. That ensured that our efforts are scientifically validated and that we can quantify our impact. Data-driven evaluation is not just about proving success, it's also about identifying gaps and refining strategies. By measuring health literacy before and after our intervention, we gain valuable insight into what works, what doesn't, and where adjustments are needed to maximize impact. This intervention was carefully designed to not only educate, but also assess and refine the approach based on real-world measurable data. To ensure scientific rigor, the model was structured into 3 key phases, with the first being pre-intervention assessment. Before attending any health literacy workshop, participants completed an anonymous, standardized survey designed to measure their baseline knowledge, attitudes, and self-efficacy related to diabetes. We assessed understanding of risk factors, symptoms, and management strategies, and gaps in knowledge that may be preventing effective self-care. We also measure confidence in navigating healthcare resources, which is a key determinant of health literacy. This assessment served 2 purposes. The first being that it provides baseline information to compare against post-intervention results. And number 2, it ensures that this educational approach is tailored to the actual needs of the participants rather than making assumptions. The second part is the educational workshop itself, which is the targeted health literacy training. After gathering this baseline data via pre-surveys, I conduct interactive health literacy workshops that are tailored to the specific learning needs of the audience. These sessions are designed to be engaging, culturally relevant, and practically applicable. The workshop covers understanding diabetes risk factors, meaning helping participants recognize early warning signs and modifiable lifestyle factors. Secondarily, practical lifestyle modifications, which includes evidence-based strategies for nutrition, exercise, and stress management that reduce diabetes risk. Thirdly, navigating healthcare resources, meaning ensuring that participants and individuals know how to access care, advocate for their health, and interpret medical information. And lastly, self-efficacy and disease management, teaching participants how to track their health, adhere to medication regimens, and implement preventive strategy. And that leads us into the third aspect, which is the post-intervention evaluation, which measures impact and helps us refine our approach. Following the workshop, participants complete a post-intervention assessment that mirrors the pre-intervention survey. And we measure improvements in health literacy. So, did participants show greater knowledge and understanding of diabetes management? We look at changes in self-efficacy. Do individuals feel more confident in applying what they've learned? And thirdly, we look at behavioral intent. Are participants more likely to adopt positive health behaviors, such as attending checkups or making dietary changes? These metrics allow us to quantify impact and continuously improve our approach. If certain areas show less improvement, we refine our content, adjust our treating strategies, and we implement new tools to enhance effectiveness. This iterative process follows the Plan, Do, Study, Act model, the PDSA model. It's a well-established framework in public health that ensures interventions are constantly evolving based on real-time data and community feedback. And so, by embedding a structured, research-based evaluation into our intervention, we're able to measure tangible outcomes rather than relying on anecdotal evidence. This allows us to not only prove impact, but also continuously refine our program to ensure we are always meeting community needs. Currently, this study is underway and data is being collected. And this data-driven approach ensures that we are not just delivering health information, but actually improving long-term health knowledge and behaviors in a meaningful way.
For anyone developing a community health program, The key takeaway here is that measurement is just as important as education itself. Without assessing impact, you may be delivering information without truly improving health outcomes. A data-driven approach ensures that, for one, interventions are evidence-based, not assumption-based. Two, programs can evolve and adapt to better serve communities. And finally, long-term impact is measurable and scalable. By combining community-driven engagement with research-backed evaluation, one can ensure that health literacy efforts translate into real, lasting change.
That brings us to our fourth strategy, ensuring sustainability beyond you. One of the greatest challenges in public health is ensuring that initiatives remain viable, impactful, and operational over time. Many well-intended programs are highly effective in early years, but can come into troubles due to over-reliance on a few individuals or short-term funding cycles, as mentioned, or a lack of integration into existing systems. A truly sustainable program must be designed from the outset to function independently of any single person. This means that leadership should be distributed, responsibilities should be shared, and the initiative must be embedded into the community fabric in a way that allows it to continue evolving long after the initial leaders or creators have stepped away. That brings us to this fourth and final key strategy, which is ensuring that the program is sustainable beyond any single leader, including myself or anybody else.
Now, true sustainability is built on three essential pillars, the first of which being empowering local leaders. One of the most effective ways to ensure longevity is to decentralize leadership by training and equipping local educators, healthcare professionals, and community members to take ownership of the initiative. Rather than relying on solely external facilitators or volunteers who may eventually move on, this program focuses on capacity building within the community. It identifies key individuals such as teachers, community health workers, and municipal leaders who could serve as program champions. These individuals are provided with the resources, training, and mentorship needed to run the health literacy sessions, organize events, and engage with stakeholders independently. This method aligns with research on the previously mentioned CBPR, the community-based participatory research, which emphasizes that sustainable public health interventions must involve local stakeholders as co-creators and decision makers rather than passive participants. Studies show that programs where local leaders take ownership have significantly higher retention rates, better engagement, and longer lasting impact than those that rely solely on external facilitators.
And that brings us to number 2, embedding health literacy into existing community structures. To create a truly self-sustaining program, we integrated health literacy efforts into existing community institutions rather than trying to build something separate from scratch. That means we worked with schools, we worked with educators and school administrators to integrate health literacy into the school system. Instead of health education being a one-time event, it became part of the extracurricular activities and student leadership at the local schools. And also with municipal government. By collaborating with local councils, we ensured that our initiative became an officially recognized community effort rather than a standalone independent project. And that also increased the likelihood of receiving continuous funding and institutional backing as well. And thirdly, we engage with healthcare systems. By communicating with local clinics, hospitals, and healthcare professionals, we ensured that the health literacy efforts aligned with real patient needs. And once again, this approach follows principles outlined by the World Health Organization, which emphasizes that embedding health initiatives into existing community structures is one of the strongest predictors of long-term program success. And finally, that brings us to our third point, securing long-term funding and partnerships. Many health initiatives struggle not because of a lack of impact, but because they rely on short-term funding cycles without a clear plan for long-term financial sustainability. From the beginning, I prioritized securing diverse, long-term funding sources rather than depending on a single grant or external donor. And this was accomplished through one, municipal support. By gaining the endorsement of local government officials, we ensured that the program was eligible for funding and we could receive municipal backing for events, training, and resources, as well as through community-based grants. We applied for multiple local, provincial, and national grants to secure funding to expand our initiatives. And thirdly, corporate and nonprofit partnerships. We engaged local businesses and health organizations as funding partners, and we ensured a diverse financial base that reduces reliance on a single source of income. Financial sustainability is a critical component of program longevity, and research has shown that multi-source funding models significantly increase the likelihood that a program will remain operational over time. The key is not just to obtain funding once, but to develop ongoing partnerships that provide consistent financial support and in-kind resources for years to come.
The most impactful community programs are not built around a single leader, a single organization, or a single funding source. They are built collectively with shared responsibility. By giving local leaders and community members a direct stake in the success of the program, it can be ensured that health literacy efforts continue to grow, evolve, and adapt to the community's changing needs. The more people who are invested in the program's success, the less likely it is to fade away when leadership changes occur. This concept aligns with sociocultural sustainability theory, which suggests that for public health interventions to persist, they must be woven into the community's identity, traditions, and institutions. When health literacy becomes a core community value, it is no longer dependent on one person or one organization. It itself becomes self-sustaining.
The most important lesson here is that sustainability should never be an afterthought. It should be built into the foundation of your program from day one. A health initiative that is dependent on a single leader, a single funding source, or a single organizational structure is inherently fragile. But a program that is rooted in community ownership, embedded in existing structures, and backed by long-term partnerships has the ability to grow beyond its founders and continue making an impact for years. If a program cannot survive beyond its original creators, then it's important to reevaluate and ensure there is sustainability. As we conclude, we can reflect on the 4 key strategies that have made this program impactful and sustainable. Number 1, listening to the community first. This means understanding real needs rather than assuming solutions. Number 2, building long-term partnerships, ensuring that the program is deeply embedded within the community and accepted by the community. Number 3, engaging youth for generational impact. This means creating a culture of health literacy that lasts beyond one generation. And finally, number 4, designing for sustainability beyond you. This means building a program that continues without relying on one person or one-time funding. Through these strategies, we have developed a community-driven, research-backed, and youth-powered health literacy program that is working to improve health outcomes in rural Ontario. My hope is that these strategies can serve as a sort of framework for other public health initiatives or expansions of this one. Whether you're working in health literacy or disease prevention or another area of community health, these principles can be adapted to fit the unique needs of your community. And with that being said, we would love to open the floor for any questions if there are. If you're curious about a specific part of our program or want to discuss how to apply these strategies to your own work or have any insights to share from your own experiences, we would love to hear from you.
Thank you so much, Harmeet and Manraj, for sharing your experiences and strategies on empowering communities through health literacy. You've definitely given us a lot to talk about. And like Harmeet said, we are opening the floor for questions. So I think I'm seeing a couple of them come in. Let's see. Our question from Malia is, any tips on how funders syndrome can be prevented in leaders? Oh, founder syndrome can be prevented in leaders. Can you speak to that?
Yeah, of course, I can speak to that. I think that is an issue that you can certainly encounter when you're on your way to creating any sort of program, along with many other issues as well. Imposter syndrome can also be an issue. I think the importance here is to always ensure, in order to avoid these sorts of issues, is to ensure that leadership is distributed not just within yourself, but with people in the community. That always ensures that no matter what, the program remains grounded in what the community needs, and it reaffirms you as the founder or leader as well, that you're on the right track. Another key aspect of that is always opening the floor for feedback. So that means whether you're implementing a certain intervention or whether you're delivering a workshop, to make sure that there is at least one way for individuals to give you feedback, whether it's on your performance in speaking, leading, or the content of the workshop you're presenting itself. That continuous feedback ensures that you continue growing the program, evolving, and it helps avoid and mitigate any of those types of issues. Me personally, what works for me is anytime I host a workshop or if I host an intervention, I'll always have some sort of physical anonymous box placed somewhere in the building on the same floor where people can leave anonymous feedback. But also for those that prefer that face-to-face discussion, I also stay back after any event or any workshop for at least 20-30 minutes for people that would like to leave any feedback or comments directly to me. And additionally, if I'm presenting any contact, I will leave my email at the end of, say, the pamphlet, the brochure, or the slide deck, so that people can also feel free to reach out to me via email. And by always continuously implementing that feedback, you can prevent a lot of those issues from occurring from my personal experience.
Just to expand on that, by the way, the one of the best ways we've avoided founder syndrome in this organization is by implementing just guidelines and protocols. So as we take a step back as leaders in this organization to ensure that we have continuity, one of the most important aspects we would need to include is just guidelines and protocols that remain consistent. So there wouldn't be any change in our ideologies as the program continues to embed itself in the community.
While we wait for more questions, I have one. I'd like to ask about something that really stood out in your presentation. The idea that health literacy is a systemic issue, not just an individual responsibility. Can you both expand on why it's so important for health literacy efforts to be embedded within communities rather than just focusing on individual education?
Yeah, I can go first on that. I think it's very important for health literacy to be embedded into community structures, whether it's schools or hospitals or clinics or local municipality, simply because one, that ensures consistent integration of community feedback and information. So for the people that we're delivering this intervention to, they get to have a strong hand in what we're doing. But also, additionally, I think it also supports the longevity of the program itself. If you're running some sort of public health program, chances are you're going to expand beyond whatever X community you're looking at right now. And so once you take a step back to focus on newer communities that you're also implementing the program in, it can be easy for the initial communities to kind of fall to the wayside a little bit and not receive the attention they deserve to continue growing. But if you have this ideology of health literacy and you teach the importance of health literacy to the community members, then they can continue the mission forward. Something really interesting and nice that happened that we didn't mention in this presentation was after outreaching to local schools and running our first few events and workshops there with the students. The students actually ultimately ended up starting their own student-run club, and they called themselves health literacy ambassadors. And they run their own events to do with health literacy outside of us now too. And in doing so, now that means even if we were able to step away from the community and in any situation, if we stopped engaging with the schools, if that were to ever happen, then we can still trust that the mission is carried forward and the importance of health literacy is still taught because we shared the knowledge that we have and passed it down to those youth, those educators, etc. And now they can continue passing that information on. And in doing so, it really ensures that the movement itself of the importance of health literacy remains sustainable over time.
Exactly. As you said, the purpose behind viewing it as a systemic issue is we want to promote sustainability for the program. We want to create lasting change. And this is, for instance, in just us weaving it into the education system as well as the municipality system. Obviously there's just educational barriers and individual knowledge, which is not enough. For instance, a person with diabetes may not understand how to manage their condition if they like they may know how to manage their condition, but if they can't afford medication or have a lack of access to healthy food, their knowledge alone won't improve health outcomes. And on the other hand, they could understand it very clearly, but there's just systemic barriers such as limited access to clear culturally relevant information, general misinformation and distrust in healthcare systems as a whole, as well as just language barriers and health literacy gaps that can make it difficult for people to navigate the healthcare system. So that's why our purpose is to embed both the two key takeaways. We want to see it by embedding health literacy at a young age so people understand it and it's just a part of their character to understand it from a young age. As we said prior, people who pick up these healthy habits from a young age, it often persists into adulthood. And of course, the second key takeaway is to bypass these systemic barriers that I mentioned already, such as just language barriers, just a lack of culturally relevant information, which prevents people from properly understanding and combating their conditions.
Thank you both for responding that. I see that we're coming up on time, and I just see a comment here from one of our attendees. If you both could share your contact details, I think maybe we could put it on the chat box if you'd like.
Yeah, of
Um,
course. I would love to connect with anybody that's interested. I can, after I stop screen sharing, I will share my email and you can reach out whenever you would like. I would love to hear from you.
Well, thank you again to you both, Harneet and Monraj, for sharing your insights and experiences. And a big thank you to all of our attendees for joining us today. And we hope that this session has given you valuable takeaways that you can apply in your own work and communities. Just some final reminders. If you missed any part of today's session or want to revisit some key points, we will have the webinar recording available on the Health Literacy Solutions Center platform by next week. The webinar slides will also be available there for your reference. And if you would like to continue the conversation, we will have a discussion thread on the Health Literacy Solutions Center, and our speakers, at least Harneet, will be engaging there as well. I'll be sending her the questions and she'll be responding directly. And also before you go, just a reminder to complete the short evaluation survey that will be emailed to you. If you are requesting CE credits, submitting the evaluation is required to receive your certificate. With that, we'll wrap up today's session. And thank you again, both, and thank you everyone, and have a wonderful day.